Hi, I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. Imagine this, the aroma of fresh peaches and cherries with savory spices in UC Davis Health's cafeteria. The chef crafts dishes worthy of Sacramento's finest restaurants, transforming institutional dining into an experience that honors both health and heritage. As we continue our Food as Medicine series, this scene represents what's possible within healthcare systems, especially when they reimagine their role in nourishing communities. I've been reflecting deeply on how healthcare engages with the social determinants of health. Everybody's probably heard about that by now, but food is one of those components. When healthcare systems step into this space, we don't acknowledge the generations of wisdom that communities already hold about these issues, specifically food's role in healing. Too often, our system's instinct is to measure, quantify, and prove value, which consumes resources that could honestly be translated to feeding people. While showing cost saving for healthcare systems does matter, I believe providing nourishing, culturally meaningful food represents a fundamental right, not just a way to reduce healthcare spending. Today's conversation with Dr. Reshma Gupta, Chief of Population Health and Accountable Care at UC Davis Health, offers important insights into navigating these complexities. She's a practicing internist leading system-wide changes, so brings the perspective of a practicing clinician. And she shares how one major healthcare institution approaches food and community health with intention and humility. In this episode, you'll learn, 1, how food programs strengthen both health outcomes and local economies. 2, the vital role of cultural connection in successful food initiatives. And 3, ways to bridge individual care with system-level transformation. Dr. Gupta shares patient stories, including a Vietnamese cancer patient who regained hope through culturally appropriate meals during treatment. It made such a big difference for her, and you'll hear it in the story. These kind of narratives reveal why thoughtful food programs matter. When hospitals partner with local farmers and restaurants, when they honor cultural food traditions, when they bring families together to cook and learn, they create ripples of positive change throughout entire communities. This is what institutions should be doing. So without further ado, here's Dr. Gupta talking about what has meant for her in her role. Dr. Gupta, welcome to the show.
Thank you so much for having me. Excited to be here.
Excited to talk to you about food as medicine, specifically in connection to caring for diverse communities. And what does this look like as a movement? Let's start off with talking about food as medicine overall. What does it mean to you? And what's your journey been to get there?
Yeah, we've been doing work around food insecurity and thinking of food as a way to get to health for quite some time. I know it's gotten a lot of attention more recently in the media and a lot of movements through DC with the White House conference around food and hunger. For us, it really is getting back to the basics of there's a number of medical conditions that are greatly affected by the food we eat, or we call it food sensitive conditions. It goes beyond hypertension, diabetes, kidney disease, mental health and pregnancy outcomes that we often hear about. Coming out of UC Davis, that has been a leader around agriculture, and also we're a land grant institution as well that has a commitment to the community. And more recently, I would say that we've expanded when we think about food as medicine beyond medicine alone or even health alone to think about that connection with food, especially for immigrant communities and folks that live in zip codes that are heavily populated by immigrants, as well as the economy. And even being from UC Davis, where we source food and really thinking about climate and that connection to food and climate. So we've taken a full 360 view around food being an avenue to empower all of these things for our communities.
That's great. That's a much more expansive definition than I feel like sometimes I get the sense of, which is food as medicine is a food prescription. to individual patients. And I think that can be a limited model. So I love that you talked about the different components. I would love for you to recap it because I'm trying to keep it in my mind, this idea of land grants and the connection to the environmental stewardship piece. How did you get connected to all that work? How do you make sure it's connected to the food as medicine movement, especially as a leader in your organization doing this work?
I think a lot of times, as you mentioned, there's a lot of hype around food as medicine in itself. And we think about food as medicine specifically as medicalized, right? We have patients with chronic conditions, and that's where we start and that's where we end. We do have workflows that are really trying to bring medically tailored meals and to do that work out of our hospital, out of our clinics. But I think what we're talking about is those extensions that try to think more holistically about this work. And so right away, I think it's almost like an onion and we're peeling off those layers. One of those first layers that we peeled off was to say, when we're implementing any program, is it going to uptake, right? Is community going to actually feel like this is something they need? We started talking to our communities about what really mattered. I think a lot of cities have community needs assessments and are bringing in methodology to understand what communities are asking. And food came up towards the top consistently every couple of years when these were done. And as we were talking with the communities around food, there's stories where we've had groups bringing food to our communities and the food sat there and rotted and it did not actually ever get picked up or eaten. What we realized is that there was this disconnect without being able to connect with communities about the kind of food that they wanted, if it's not recognizable food. And so the first layer of that onion was trying to think about culturally palatable food and relying on a partnership I developed with our head for equity, who's got deep relationships with the community and with different communities in our region, very diverse area of the country that we live in, as well as our head chef who knows how to make those foods and understands the fruits and vegetables that need to go in them. And a lot of that work in collaborating with the thinking about economy. So when we're thinking about how we deliver food, is our food coming from and getting sourced from our local region? Are we investing in the farmers in our region? Are we sourcing food in a way that's advocating for local restaurants that are often small businesses run by these communities as a way to tie to the economy and the climate as well?
I bring this up a lot. Food is way more than food. It has so much meaning for people, including history, culture, and memories of what you ate to celebrate holidays, or your mom cooked. We need to be cognizant about it. You mentioned part of the work is focusing specifically on access and food insecurity. I think there's a component of food as medicine. We think of disease-oriented approach of somebody who has diabetes, hypertension, you name the condition, and then we're going to prescribe food to lower their risk. What I saw from the work that you all are doing was a large focus on food insecurity. And we know food insecurity itself has higher risks. I think you had some internal data that you supplemented with some outside data to have a comprehensive picture about that. But tell me about what you noticed or realized about food insecurity and why you chose to focus.
Yeah, that's a great question. I think in a lot of places when we talk about wanting to address food insecurity, we think about it in terms of the quantity of food only. So one thing I just want to clarify is a lot of places actually food is available and the quality is the issue. Fresh fruits, vegetables, and produce are quite hard to access and costly. And I think especially in certain communities, when we look at how much it costs to get vegetables or how far people have to travel to get to a grocery store that has them, it's quite far and it creates a huge barrier. So we started looking at this and we realized that in our own data, it's hard to be proactive to provide resources to our patients when we don't even know how many have food insecurity. When we were looking, I want to say almost 8% data on food insecurity after screening in our medical center. That means there's 92% missing. When we started looking at other places around the country, it's really similar in terms of the numbers. We're basically saying that even in some of the best focused primary care practices, maybe they're up to 30%. 70% of the data is missing. So how much impact could we have if we really knew the story of food insecurity? Some places have health exchanges where they can get more data by sharing information around social needs, including food insecurity. We purchase data because we're not in a region that has that. And we try to validate it to understand how well it works within our communities. it just showed such a huge picture of how prevalent it was. In California, for example, the rates of food insecurity are often like 13.5% or so. During COVID, it went up. Ours is higher by a few percent, but we noticed in certain communities, it's even higher than that. Without that data, we wouldn't have been able to do that outreach in a proactive and thoughtful way. It's made a world of difference to be able to do that. And I think the other thing is we're thinking about this by quality. So it's not just quantity. It's really thinking about what healthy food means, what wellness is, and again, in that culturally palatable way, what ingredients could we exchange to still maintain the culture, those memories, those grandmother's recipes handed down, to teach people that it's not that the food they grew up with was harming them. It's not that grandma's food was harming them, but you can maintain that culture and do a quick exchange of certain ingredients and still get to wellness with maintaining those same dishes.
Thank you. I think I've learned constantly with this podcast, and the conversation around food has evolved. We talked about the quality rather than quantity and the supply and access of food. The next step that is interesting is the barrier for some communities is the access, but then it's also about cooking and actually eating as a community. I think we are in somewhat of a crisis of social isolation and lack of communities due to a number of reasons. I'm in connection with the senior center, and their whole purpose has transformed, especially after COVID, to provide culturally palatable meals. They have a chef specifically deliver on a vision that it's not like buffet style. You'll come, take food like a food hall and sit in a row of tables, but it's actually like a dining experience. They have tables, they have napkins, and then somebody comes and actually serves your table with the food that you like. So really focusing on building community around food too. I've been inspired by that vision. Looping back to your building this program out as Food as Medicine, after we ensure supply and access to high quality food, what does it mean to build community around food and making sure it's nutritious?
That's a great question. We talked about culturally palatable foods. So I want to bring that into this discussion as well. When we talk about food that's healthy, it's often take out the sugar, take out the salt, right? Use this ingredient instead of that ingredient. But there's this component around the taste of the spices, the specific kind of vegetables, and the specific kind of fruits that people are used to seeing from their family or when they themselves lived abroad and they're immigrants themselves coming over here. And I think what happens with that social isolation is that some other fruits and vegetables or things that get put in, a lot of times when we get vendor-based food, it's not recognizable. When we talk about culturally palatable, not only the taste of the spices, but it's that recognizable consistency of the food, or that it touches on those memories. The fact that food is so tied to culture and also to folks' role in their communities. One of the things that we've really done is try to incorporate with connection to some of our community-based organizations. We work closely in the Sacramento area with a food literacy center who has connections into different areas in the region of Sacramento where there's community organizations that can get very local and bring communities together, but to empower those families to teach at a family level, first of all, and not necessarily even at an individual level, and to bring families together around cooking classes, around breaking bread together, about the ability to talk about food and to have that community engagement in that same way. It's both, I would say, the taste of the food, the kind of fruits and vegetables that go into it that make it authentic, and then being able to really break bread together and sit down and share those stories. I think when you bring up that social isolation, there's this idea of being able to get out of the house and meet new people and connect in new ways through that process that's really healing for folks that are somewhere new where they really don't have that same community like they used to.
I think it's true for many of our societal issues, including gun violence, in that when healthcare steps in as an important stakeholder, and that we know food, gun violence, name the topic, is affecting the health of our patients, that we want to contribute to the change. But we have to be intentional because there's been so many people already doing the hard work, and we don't want to take credit actually or cause harm because we come in without prior knowledge or connection to community. And I think that can happen with a lot of issues. We definitely can't just sit in the sideline and watch this tremendous problem of lack of healthy, high-quality food causing health-related illnesses. And going back to the question, which
I want to be intentional about is how do you make sure that healthcare is collaborating appropriately with the community? And what steps did you take to make sure that happened?
I think that's one of the biggest things that as we all go into this type of work, we need to reflect on. One of the first things that we did is we brought together some of the leaders internally to talk about understanding the history of programs talking about food, what is happening in the community around organizing food, and where there's been mistrust. Food is actually, in our region, being an agricultural center, a key focus in terms of the economy, understanding as health systems what those groups are, where those consortiums are, what's most important to the community has been vital. Our first thing was connecting with our community organizations to understand in the past, especially around medically tailored meals, what didn't work, what has worked, and what's most important. A lot of what I said came up, which is that free food isn't necessarily what's going to change people to move behaviors, but it's food that they can recognize. It's food that is tasty, where they actually want to reach for that versus something they're going to see their friends getting in school. So I mentioned that delivering free food actually sat on the shelf when that was provided in terms of meals. So that was a really big lesson learned. I think the other piece of it is doing it together. There was a desire from a number of the communities to learn how to prepare food for families and to do it together. So it wasn't teaching classes where an individual person comes in. There's a lot of interest from the community to have their whole family come. We may have not learned this as adults or as parents, but we want our kids to learn some of these habits really early. So can we bring them? Can we have students or children come and actually join some of this? I think a lot of it was listening to people who have been in that field for a long time in the community and taking their lead, more so than trying to come in and lead it directly ourselves.
Yeah, I think that's so important. I went to this conference a while ago. It's a collaboration with, I believe, Harvard and the Culinary Institute of America. One of the main takeaways is that healthy food can be delicious. And it was like such a key point because I think there's been this narrative that bad food tastes good and good food is healthy, but not a lot of people like it. That is not always true, but there's, I think, a moral aspect to it too. It gets complicated, but the whole point of that conference was that cooking nutritious food can be delicious, and we're going to show you how. And this is healthy for you, and it's okay to have that vision rather than the alternative being food bank style. Let's get cheap, maybe marginally more nutritious food than McDonald's, and then call it a day. Hopefully you'll get healthier. And just an alternative reality that I think of, like how it could go, and making sure that we know what our vision is in the movement.
I think that's why the cooking classes are actually really popular, especially amongst kids and families, because it makes it fun. And so you'll have kids who have thought about kale or a green leafy vegetable, and they say, I don't like that. I don't want that. I don't want broccoli. But then when you actually have them make it in a way that's fun and they eat it, it's like the first time you just see that their whole mindset around food changes. Even trying new things that they never would have tried before opens their minds to, instead of saying, no, that's different.
Now I want to go down to maybe, if you can, some examples of specific communities that you've addressed. Is there a large immigrant community or a specific community that is in your neighborhoods?
We have a really diverse community here in Sacramento. It's representative of a lot of the state, but a number of different communities from South and Central America. And so even vegetables and fruits that fit in a certain cuisine are different in different neighborhoods. We have a large African-American population here as well. That's one of the populations we've been focusing on in terms of where we see disparities in health outcomes and tying that to food, being really thoughtful about those types of foods, but really broad demographics here. And we also span rural to semi-urban to urban areas as well, which is a whole nother story in terms of being able to say that accessible, culturally palatable food exists in those rural areas versus deeper into the city.
10 years from now, you've achieved your vision of whatever you want for food as medicine program for the Latino community in all its diversity. What does it look like and what are you doing for that community? I would love to hear that vision.
I would say this has given me 10 years to build some of them. One of the things I think would be great is for us to legitimately have the ability to deliver healthy foods that they can actually say, I want to eat this specific thing that my grandma made and be able to order it and it's able to have it delivered to their home in a way where it's low cost to them, that it's coming from food that's local, maybe even local restaurants. The food's not only creating not a barrier around transportation to get it and to have it be recognizable food, but food that's investing in their neighbors. I think the other is being able to say, just like what you had said before, that with the spices and with the flavors of bringing in fruits and vegetables that bring in the sour, that bring in the sweet, right? We're in cherry season here in California right now. Peaches and cherries and those types of things can add so much taste to the food without all this extra processed stuff that we put in would be my ideal. And to be able to offer that kind of food in the school system as well, where most kids are getting a couple meals a day out of their 3 meals. So we're not having to go through the bulk ordering of processed foods that are cheaper for our schools and actually able to provide them with full foods that are coming through this avenue in a way that's cost effective for them. My goal is that it's not just the ability to make the food good tasting, fun to make, fun to eat with the family, but that our policies follow it so that it's affordable and we can actually do it across our communities and across our schools.
I love that. I want that for everybody. Make it happen. I think the follow-up question to that is the affordability and cost, which everybody will always bring up about who's going to pay for this. I think there's probably a lot of ways to answer that. A lot of the innovative projects, there's different waivers. It's really focused on Medicaid population. Different programs. California has Medi-Cal, which has helped spur some innovation because social health can reduce risk of a higher risk population, which Medicaid typically tends to be. So there's a way to have this cost justification for food. I haven't seen a clear vision for one, if we're looking at insurance, like commercial and Medicare, they are often slower and have lower risk patients, but I'll say that for myself. If I get medically tailored meal, it might just be more costly for my insurance plan because I rarely go into the doctor, right? So I think for the average population, when is it justified? I think the payer level from insurance is one. The second is as a community and society level of what does the policy advocacy look like and what should we as healthcare professionals be advocating for?
Yeah, I'm right with you in terms of where the barriers come from, like why we see these policies coming out primarily with Medicaid, but then we don't necessarily see it expanded to Medicare or even some of our commercial plans outside of innovative programs popping up. It really is about how do we fund this when it comes to the number of patients that we're addressing. I think we started with Medicaid for a reason, which is that it's a focused population of patients where we know there's disparities, there's higher prevalence of medical conditions that are food sensitive. It's that diabetes, hypertension. And investing in those early also help reduce the progression of them into strokes and heart attacks and things down the line. So from a financial argument, being able to invest in those, it's shown time and time again in communities that have done it, that there's real outcomes that come from that. And I think that's why for communities that also struggle with transportation and access to foods, certain states, certain regions have committed to pilot these programs like California has done for medically tailored meals or at least access to fresh produce, or other programs that have existed for a long time to provide vouchers or groceries for communities. I think what's different now, part of this has to do with the data, because I've seen it even locally for us. I can now look at food insecurity across Medicare, which a lot of times places don't have data on to even tell the story of how common is food insecurity in their Medicare or commercial payers that aren't covering that. And the truth is, it's actually really large. And it's a little bit lower, but not by that much in some of those communities, especially Medicare, that's a vulnerable community in a lot of ways. We have very little ways to pay for that right now. And I think the conversation has to flip. So someone told me this once at a conference, and I've really held it tightly. We do not give a lot of pushback when a drug company creates a medication to prevent a heart attack. We give aspirin, we give blood pressure medications, and they are funded by our insurance to cover those conditions. But we will not pay for food that would have prevented that from happening in the first place. we'll spend thousands of dollars on the medications after patients get sick. And it's really reverse thinking. If we look at a population level and learn from the Medicaid programs that have done it, it's a no-brainer that it would benefit the population in terms of Medicare. But when you're talking about where is that money going to come from, that's where there's a lot of pushback to say, how are we reframing how we're funding? And how do we invest in those communities to show that return on investment is there? When you look at that data, costs of the hospitalizations we cover, costs of the ED visits, costs of those medications, right? Because that's the alternative that we've already agreed to pay for instead of the food.
Yeah, that's so true. I think there's less resistance to something known like medications, which we assume has been proven through RCTs, and the variables so tightly isolated that the hope is that if we prescribe this medicine, that'll achieve the outcome that it's intended. When compared to food, people are probably still asking for evidence if it'll decrease costs or achieve benefits. And it seems like food is harder to control as an intervention of this exactly medical tailored meal and no other variation will achieve the outcome. It can be a little more varied, and it's actually like a paradigm shift on how we do that. And I think the other big point is that prevention has been hard to instill in healthcare. Some people call it sick care, you name it, whatever. But part of that problem that I've been thinking about, and I don't know if it's come up for you, is that especially with food as an intervention, the prevention can be years to decade out often. And many people change insurances. So there's not an incentive for a single insurer to invest compared to Medicaid. How do you build the community level perspective from multiple private insurances to work together in an incentive like that? Have you been able to have those conversations saying it may not benefit any one of you this time, but all of you will benefit in 5-10 years? I don't know if that conversation is taking place or what that looks like.
I think for me, where I've seen it pop up in commercial is payers is really where you have early adopters who, from a cultural perspective, believe in doing that preventative work. Certain communities want to get insurance, or their employers are getting insurance from places that want to invest in wellness. But I think you're right in that some of the outcomes right now, they're not set up in the way to incentivize that. I have hope in that a number of states are investing in new payment models around food as medicine or wellness and food. And I think the results that come out of those states are going to help guide some of these different forms that the model can actually get you those results. And I think they're promising. I think there's other issues that happen in the state about the programs not taking off as fast as they do, or the meals not getting the implementation of it never happening perfectly. But where it is happening, the results will follow because studies have shown that. But the question is, if Medicaid can show that, and Medicaid translates to Medicare, which is a huge group of patients, a lot of the commercial groups will follow. I do believe that would be true. And I think that's where you're going to be able to see that investment. We've said the same thing around cancer screening for a long time. And at some point, the funding to make some of that screening pass does happen. I'm still very hopeful that this is the time for food, that it's come up in national attention, and this is the time to push it forward. I think it's not about needing to have 10 more studies saying, does food work or not? The question is really about the implementation at this point. We need to understand where things work so that those policies can follow. Even though smaller payers will follow if Medicare is able to do that. That's just my thought.
We're just thinking out loud here, but I'm hoping that's true. I think you're right in that most people follow Medicare. So whatever Medicare makes the decision for, I think other insurance plans follow. I think that's an important point to remember. We're getting too wonky into policy probably for my audience. I'm going to step back and ground us. What is the favorite meal that your chef has cooked?
Yes. Our Chef Santana is a legend here at UC Davis, and I think he's well known through the region. If anyone has the ability, come by, stop by. Our cafeteria is actually rated as a top place to eat because the food is, like we said, it's bringing in all these local produce from around the region. And so it's fresh and it's not the normal food that you expect at a hospital. It's not mushy and brown and unrecognizable in terms of what it is. It feels like you're almost at a gourmet restaurant sometimes when I'm there. One of the best meals that he's made was pork chops with some of the fresh peaches and cherries that we have had locally, comparable to any great restaurant that you're going to eat here in Sacramento.
Do you have any success stories or specific narratives? Because I know that resonates with folks sometimes when we're talking about this abstractly. Is there something that stood out to you in the last year doing this work that you've shared?
Yeah. I have a patient who is Asian American and was diagnosed with cancer. We'd been working together for a number of years and following them through their cancer treatment with the oncologist. And they underwent radiation, they underwent chemotherapy. And like many cancer patients, they'd lost a lot of weight from their disease. One of the things that was really hard was they didn't have a lot of family here. As they were sick and going through their illness, they didn't have the energy to cook. They didn't have the energy to go to the grocery store to bring, especially the Asian grocery store, to get the food that they're used to. And so they were able to get food delivered to them. It wasn't the food that they wanted, so their appetite wasn't there and they kept losing weight. It was through one of these programs that I mentioned that our hospital offers where there's actually produce bags and recipes that are there or pre-made meals that she was able to connect with the food and culture of her own. She was Vietnamese. And being able to have that made a world of difference. I remember seeing her almost every month for about 6 months and just seeing her weight drop, her energy drop. She became more depressed. Not much had changed other than the fact that we were able to take one of a joy in her life, which was food. She was actually a foodie back in the day, and bring that back to her, change her whole outlook. And she gained 15, 20 pounds back just by the fact that she could enjoy that food. She'd been isolated from her family, and being able to call them and share a meal, even if virtually, was such a huge effect on her mental health. It made a world of difference. And I think we sometimes talk about it really academically, but that connection to food is so fundamental to our culture, and that connection to people. That's what we're really working for with these programs.
That's incredible. That's real people, real stories, real lives that we can change with this. And I think it's important to remember that. One last question. Any advice you would give healthcare professionals wanting to establish trust and build relationships with community to address food insecurity?
Be ready to listen. I think that's the most important thing in working with communities, and give that space to really dig in and be the learner, knowing what's happened before, taking on the history of your organization within those communities. I have learned so much, not only by the community within our health system. It's rare that you're going to see the person in charge of population health with the equity leader in the institution, with your head chef planning a program with the community, or even just sitting in the same room, to be honest. And I think that's a huge thing. The other thing I would say as advice in working with community is don't drown by trying to make it 100% perfect. It's okay to step out, listen, learn, and expect that you'll recover together. I see a lot of folks who are nervous about starting because they haven't done it before. There's people that are going to give you the grace that you're trying to do the right thing and that you're there to listen and learn. And I think that's probably more important than any specific part of any program we do.
Thank you so much. Thanks for coming on to this podcast, Dr. Gupta.
Thank you so much. Really enjoyed our discussion.
As always, thank you for listening to Healthcare for Humans. If you've found any value in this podcast, I have 2 quick requests. 1, please leave a review in the podcast app that you're listening to my voice in right now. It really helps others discover the show. 2, share this episode with anyone who you think might benefit from it. For easy access to all our episodes and to support the podcast, visit www.healthcareforhumans.org. There you'll find our content clearly organized by topics, countries, themes, to help you choose what to listen to next. Until next time, this is Dr. Raj Sundar, reminding you that culturally responsive care leads to better patient outcomes. See you again soon.